In the April 5th issue of JACC, there is a paper entitled "A 1-Hour Combination Algorithm Allows Fast Rule Out and Rule In of Major Adverse Cardiac Events." I am here with the author of the accompanying editorial comment, "How good does it need to be?" And you may recognize the visage, certainly the voice, Dr. Allan Jaffe, who is chair of the Division of Critical Core Laboratory Services and a professor of laboratory medicine and pathology at Mayo Clinic.
And a professor of cardiology.
Whoa,
I'm still a practicing cardiologist.
You are a busy man, and thank you very much for some time, because this is an interesting topic in general. It's the use of high-sensitivity cardiac troponins, of course, and this paper in JACC really builds on the protocol used by the European Society of Cardiology guidelines to rule in or out AMI. So what did you think of the paper? Let's talk about that.
First let's start with the primary postulate of the paper, which is they wanted to add risk stratification and ECG findings at the front end and ask whether or not that improved the algorithm. It's not surprising that it did, but it did substantially improve the specificity, in particular the rule-out arm, and it also improved and reduced the event rate at 30 days, which was used as a surrogate outcome. I don't think that's surprising. It's something many of us in critiquing those guidelines have suggested should be added. Unfortunately, they didn't codify how they did that. And so telling our listeners how to implement that is difficult. I think we all do that intrinsically when we see patients, but I would hope we could have tested one or another of the very many risk stratification algorithms that are out there. I think that would have helped.
Where should we be going then?
Well, my major concern is not with that component, which I think is a good component to add whatever risk stratification and whatever triage program we use. But I have intrinsic concerns about the 1-hour rule out. And that's why I wrote the editorial, "How good does it need to be?" First of all, I think it's important to say that ruling out and ruling in probably are going to need different metrics. The assumption that if you don't rule in, you rule out, probably is overly simplistic if we want to do this very rapidly. And there are probably some patients who we can rule out very rapidly. There are patients who have very low values for cardiac troponin, likely because all the comorbidities that lead to increases in cardiac troponin, all the more comorbidities that lead to atherosclerotic disease tend to float those values up, so you won't find very low values. And then the approach taken in this paper, which is if you don't see a change, they can be ruled out. I have intrinsic concerns about that criteria, and the first one as well from two perspectives. The first is most of the studies don't have enough early patients. And it's clear that if you're at 3 or 4 or 5 hours and you don't have an elevation, you have a very low value, you're probably okay. But what about the patient at 1 hour or 2 hours? And if you look at all of the studies in this area, none of them have large numbers of early patients. That's a key issue. The second important issue to me, and it comes from the laboratory hat, which is that if you take a look, they want you to make a distinction between 3 nanograms per liter and 5. And in all due respect, the assay isn't capable of doing that. The cardiac troponin T assay, as it's presently configured on the present instruments we have, if the values are low, you can't make that distinction. Now, if they're high, you might be able to, but imprecision is greater. So they're then proposing a criteria that can't possibly work and eventually will cause problems. So the rule-out arm has a good principle. That is to say, you want to look for very low values and you want to look for the lack of change, and eventually we'll figure that out. But what we need to be sure about is that the people at the very low end and that present very early don't somehow overlap with those rule-out criteria. And in the one published analysis from utilizing very low levels, patients within 2 hours had a marked fall off in the negative predictive value. So we've got to be careful to protect patients. The rule-in side is another issue. I have issues with that side as well, which is why I think it needs improvement as well. The studies that have been done take patients who present with chest pain. They don't take, and they intentionally eliminate, patients who present very atypically, who are elderly, who have renal failure, many of whom have elevated troponins to start with. And one of their criteria, in addition to the 99th percentile, is an arbitrary increase to about 3 times the 99th percentile. And it works okay if you take the more classical chest pain patient, but it is unlikely to work nearly as well if you take that absolute threshold and you include critically ill patients, patients who are elderly, etc. And my concern about that is that we don't want to have a situation where we're having different protocols to evaluate MI in one group versus the other, or different ones in the ED compared to what we do in the intensive care unit. And if we do these studies in a more comprehensive group where we include all comers, I fear that value is going to have to go up very substantially. And I think we need to be careful to make sure that that happens.
The 1 hour seems like a very popular point to study, the rapid rule-in and rule-out. What's reasonable? What do you think the high sensitivity troponin assays are going to do?
Well, I think that you can do an at presentation rule out if you select the low risk group with a low risk ECG, has a very low troponin. That's probably going to work. And you could argue what percentage of the population it is. If you look across the literature, in some populations that have been recorded, it's 60%. I think that's much too high for most of us. If you look at the prospective data, it's around 20%. So 20%, we probably could move out very rapidly, low risk, but I think you need to do a pre-hoax stratification to do that and make sure they're low risk. Similarly, I think that you'll see changes in the vast majority of patients who rule in reasonably rapidly. Maybe not 1 hour, but certainly 3. And if you have a big change by 1 hour, that probably is good enough, assuming the clinical scenario is good enough. So I think that the ends will be substantially served by maybe 20 or 30% at the front end, maybe 20 or 30% at the back end. I think what the decisions that have been made about how to use the protocol have made the middle ground, what they call the observational zone, much too narrow. And it's going to be bigger. And for those patients, maybe we'll need 2 and 3 hour sorts of evaluations, but it will work.
Well, the way you put it in the EC is the way forward is complex but clear.
Yes. And I think we need larger studies that do upfront risk stratification. We need diverse populations. For example, an important issue, women tend to have lower troponins than men. From first principles, you might think they need lower values. There's conflicting literature about that. I would argue the reason it's conflicting because they don't have enough women with MIs. So you've got to have enough early MIs, enough women with MIs, and then you've got to have a good look at what the assays can do and can't do. And I think that will change the metrics. But I do think that a large percentage of patients will be evaluatable within an admission, another subset at 1 hour, and finally there will be a subset we'll have to be careful about because some reports have suggested that there are patients who have myocardial infarction who don't have a delta or change at all because they come in late at a time when it's hard to see that change, in particular if you're not reperfused, since blood flow is what is responsible for the biomarker washing out. Their curves go down very slowly, so you say there's no delta. Those patients need to be protected as well. So I think we need to be more clever, more comprehensive, and a little more complex than we've been.
Well, in the title of the editorial comment, you ask, how good does it need to be? And you conclude that the approaches suggested are not yet good enough.
Correct. I think they will be eventually, and I think that's really what those of us who are involved in doing the research and who work with biomarkers need to do. I think we can. I think we're attracted to simple solutions in a complex area like this, and clinicians say, oh, high sensitivity, and they're scared to death of it in the United States. And so you give them a nice simple algorithm and they're apt to sign on. I think it's a little bit too early to sign on, and I'm worried that if we're not careful and that we don't speak out about what are the ambiguities and where the gaps are, that we could inadvertently hurt patients. But we will get good enough.
I write all the summaries for Excel, so all those summaries that come with every issue. And so I hear your voice constantly. So it is such an honor to have a chance to get you in front of a camera and chat. I appreciate that a lot.
It's my pleasure to be here, and I'm sure that your viewers can take the images and make dartboards.
Absolutely. And this is in the April 5th issue of JACC, so please check that out, both the regular paper and the editorial comment by Dr. Jaffe. For CardioSource World News, I'm Executive Editor Rick McGuire.